So in the previous lecture, we were talking about the muscles on the anterior aspect of the thigh, and we talked about different muscles, but we left out the quadriceps because we said that we are going to talk about that in a more detail in the upcoming section. So this section is about actually one of those group of muscles, which is the quadriceps femoris, which are a group of muscle of the anterior aspect of the thigh. So we talked about iliopsoas, tensor, fascia, lata, and sartorius previously, but we left out the quadriceps. In this section, we're going to talk about it. And the quadriceps femoris is actually a group of muscles on the anterior aspect of the thigh, consisting of the rectus femoris, vastus lateralis, vastus intermedius, and vastus medialis. Now, one important thing to understand is that we commonly refer to the quadriceps femoris as a multi-joint muscle or a two-joint muscle because it actually crosses or covers both the joints, the hip joint and the knee joint, and it has action on both hip and knee because it results in hip flexion as well as knee extension. But that is when we talk about the quadriceps femoris as a whole group. So quadriceps femoris as a group may be a multi-joint muscle, but it's not altogether right to say that individually they are all multi-joint muscles because only rectus femoris is a multi-joint muscle. But if we talk about the vastus lateralis, vastus intermedius, and vastus medialis, they are not multiple joint muscles because they do not cross the hip joint and they only act on the knee joint. Moreover, rectus femoris is actually located superiorly or superficially. So rectus femoris is located more superficial and it is more profound if we talk about the surface anatomy, and on both of its aspect is the vastus lateralis and vastus medialis. But in terms of surface anatomy and even in terms of superficial dissection, we cannot visualize vastus intermedius because it is located beneath the rectus femoris and thus it is hidden. To visualize the vastus intermedius, it is necessary to actually remove the rectus femoris so that we can visualize the vastus intermedius muscle. So now let's take a look at all of these four muscles in the quadriceps femoris one by one, starting off with the rectus femoris, which is most superficial located. So here we have the quadriceps femoris, and you can see that there is actually vastus intermedius present beneath it. And another very important thing about the rectus femoris is that it is involved in the pointer injuries. It can also cause avulsion fractures in the anterior, inferior iliac spine in collision sports. And another important thing biomechanically is that it is a multi-joint muscle. So in terms of its individuality, it is hip flexor as well as knee extensor, and it is a very strong knee extensor, and it's because quadriceps femoris is known as the primary mover in terms of knee extension. So as already mentioned, it arises from the anterior inferior iliac spine and it inserts into the tibial tuberosity via the patellar tendon and encompasses the patella as well. I already mentioned its function, that which is hip flexion and knee extension, and talking about its nerve supply, it's via the femoral nerve, and the nerve roots include L2, L3, and L4, and they are actually the same for all of the group, which is the quadriceps muscles L2, L3, and L4. So now talking about the vastus lateralis, it is located on the lateral aspect, and it arises from the posterior aspect of the thigh, in fact, even though it is a part of the anterior group of muscles. So it starts from the posterior aspect because linea aspera is located posteriorly and then moves anteriorly and then attaches on the tibial or tuberosity via the patellar tendon. But its contraction not only actually pulls the patella upwards and causes knee extension, but it also pulls it laterally. So it has slight oblique line of action of the force, which needs to be counteracted by the vastus medialis because that is located on the medial aspect and that needs to counteract its force. So in terms of its function, it is a knee extensor and not a hip flexor because it is not crossing the hip joint. It's just a single joint muscle. But if we talk about the group of muscles, we have the quadriceps femoris. Then in the sense of the group, it can be said that the group has a function of the hinge joint as well. So the nerve supply is the same for the vastus lateralis as the rectus femoris, which is the femoral nerve, and the nerve root includes L2, L3, and L4. Now talking about the muscle which is opposite to the vastus lateralis, located on the medial side, is the vastus medialis, and once again the attachment starts off from the posterior aspect through the linea aspera, and then it moves anteriorly, and then it inserts into the tibial tuberosity via the patellar tendon. But once again, the you can say the orientation is of such a way that it not only pulls the patella upwards causing knee extension, but also pulls it medially. So the line of action is once again oblique, and thus, as already mentioned, it is contracted by the vastus lateralis. So vastus lateralis and vastus medialis actually counteract each other's force, keeping the patella in the center and allowing smooth movement of the knee joint. Now once again, the nerve supply is the same, which is why the femoral nerve, L2, L3, and L4 are the nerve roots for the nerve supply of the vastus medialis. The last but not the least is the vastus intermedialis muscle. It is actually present beneath the rectus femoris, and it is again the center or in between the vastus lateralis and vastus medialis. And the attachment or the origin is from the anterior femur, unlike the vastus lateralis and vastus medialis, which actually start or rise from the posterior aspect and come towards the anterior aspect. It starts off from the anterior aspect, and it inserts via the patellar tendon to the tibial tuberosity, and its function is once again knee extension. And as it is located in the center, it only glides or pulls the patella in an upward direction, and thus its line of action is along the longitudinal axis of the femur and not on the medial or lateral aspect, so it is not oblique. And once again, the nerve supply is via the femoral nerve, which is L2, L3, and L4. Now, talking about the innervation of these muscles, we can see that all of them have the same nerve supply as already mentioned, which is by the femoral nerve, and the spinal segment is also the same, which is L2, L3, and L4. And perhaps because of the same action, same function, same common insertion, and same nerve supply, they have been categorized as a same muscle group, which is the quadriceps femoris. So sometimes it is possible that we see patients that have paralyzed, which means flaccid weakness or complete paralysis of the quadriceps muscles, and sometimes we see paretic patients in which there is actually weakness of the quadriceps muscle. So in both cases, there is actually insufficiency of the action of the quadriceps, which is knee extension, because they are the primary movers in knee extension. Thus, the patient comes with impaired leg extension, and as impaired leg extension manifest in inability to extend the knee actively. So what happens is that the patient, when the patient attempts to walk, he or she presses on the distal end of the thigh in a posterior direction to extend the knee during walking, because it is not happening actively, so they are using their hand to passively extend the knee during walking. And that is one of the common clinical manifestations that you would see in such patients, which they are actually doing to prevent the flexion in the knee joint. And if you see any such deformity or biomechanical anomaly in function, then you can perhaps actually make a diagnosis or reach towards a diagnosis that perhaps the patient is having a paralyzed quadriceps or a paretic quadriceps. Another very common condition is patellar tendinitis, because our lower extremities are involved in a lot of movement, and because the quadriceps is one of the strongest muscles in our body, and they transmit a lot of force through that single tendon, which is the patellar tendon, during running, walking, lifting, and all other functions. It may sometimes get inflamed, which is known as the patellar tendinitis. So here you can see in this picture, this is actually the patella, and this is the patellar tendon attaching to the tibia tubercle, and this sometimes becomes inflamed. So that is because of the overloading of the knee extensor mechanism and the hyperactivity, which leads to tendon micro tears. And if they are not followed up by the regular healing process, the accumulation of these micro tears can lead to dysfunction of the musculoskeletal system in terms of patellar tendinitis. And it is a vulnerable site because patellar ligament is attached to the patella and the tubercle, and it has to deal with a lot of forces generated by the quadriceps, and overuse injury can lead to degeneration and tendon tearing as well. Another very important biomechanical aspect and phenomena that we see in a lot of patients is the dysfunction of vastus lateralis and vastus medialis. What happens, for example, in any type of injury or trauma, or even in knee osteoarthritis? So whenever there is any such condition, there is actually inhibition of the global mobilizers, and there is inhibition of the local stabilizers. So the hyperactivity of the global mobilizers actually and leads to the dysfunction, because there is weakness of the local stabilizers, and there is actually a dysfunction or discrepancy between the function of the two muscles. So if we talk about the knee joint, here we have the global mobilizer, which is the vastus lateralis. So it is prone to get short or prone to get hypertonic or hyperactive. And vastus medialis, on the other hand, is the local stabilizer, which is prone to get weak, and that is more common. And what happens is that when the discrepancy develops between vastus lateralis and vastus medialis. So vastus lateralis, because it is hypertonic and short, it pulls the patella towards its side, which is towards the lateral aspect, and thus causes lateral patellar tracking, which can lead to abnormal joint mechanics and even lead to patellofemoral joint dysfunction and patellofemoral pain syndrome as well. Similarly, sometimes the patella can also be pulled medially by the vastus medialis, which leads to the medial patellar tracking. But lateral patellar tracking is more common because vastus lateralis is prone to get short during a dysfunction, and vastus medialis is prone to get weak. And because of that abnormal patellar movement or abnormal patellar mechanics, there's actually pain and degeneration and also loss of joint stability. So that was all about the quadriceps muscle group, which on the anterior aspect of the thigh, as well as the clinical significance of the quadriceps muscle groups. And I hope you learned something new out of it. So if you want to learn more about such lectures, so keep on watching sqadia.com for that, and thank you very much.